welcome to this webinar on the non-stop route to OR for the trauma patient, which is brought to you by ESTES, the European Society for Trauma and Emergency Surgery. Today we have a great list of panelists for you. We have Juan Duchesne from Tulane in New Orleans, who will be giving us a couple of case presentations. Raul Coimbra from California, Shahin Mohseni from Örebro in Sweden, and Mansoor Kahn from Sussex in the United Kingdom. And after that brief introduction, I think it's time to hand over to Juan Duchesne for his first presentation. Juan.
Thank you so much. Good afternoon to everybody and good morning to people in the United States. I'm going to be presenting two cases. The first case is going to be about penetrating trauma with questions and answers, and then followed by a quick synopsis of one of our studies done, multi-institutional studies done in the United States. So here we go. We're going to start with this is real life case scenarios from EMS ambulance service, where they are basically doing quality and improvement education for EMS for any transport. So what you're going to see is real, is not a mock presentation, is a real case scenario. So we're going to start with the first signal that we got from the EMS team when they went ahead and went to the scene where a person was shot in the chest on the left side after a home intrusion.
So we have an entrance through going through. He has lung sound. Blood pressure is 85/62.
Okay.
Could you see how what I'm thinking
Dying.
with the way the gunshot wound is?
Feel the please.
Enter here.
Please.
All right.
So that's our first presentation, the first thing that we received from EMS on the ground. And as you can tell, the patient is in extremes. He looks diaphoretic. He looks like he say, I'm dying. And his systolic blood pressure is in low 80s. So let's go to our first poll question. Jonathan. We cannot hear you, Jonathan.
You're muted, Jonathan.
All right, Jonathan, you're muted. We cannot hear you, my friend.
Third time lucky. Based on the patient's vitals, the best thing EMS can do is, and I think most people have responded already, so I will share the results. And 77% think that the best thing to do is to just scoop and run, and 23% would scoop and control with ARC. You'll have to explain what ARC is, I think, Juan.
Yeah, so I can, oh, here we go. We have the questions. So these are the questions. This is the first one. Don't look at the second one. So the question was, based on patient's vitals, the best thing EMS can do is to press on the gas, stay and play with advanced resuscitative care, or scoop and control with advanced resuscitative care. And the answer, Jonathan, was?
That the vast majority would just scoop and run.
Okay, so scoop and run. So the scoop and run technique is basically what we've been practicing in the United States, where we basically want to put the patient in the back of the ambulance and run as fast as possible to the emergency department. The mortality have not changed using that technique for the last 20 years, ranging 20% to 30%, especially for non-compressible torso hemorrhage. And ARC means advanced resuscitative care, which basically is an adaptation of what the military is using into the civilian world, where basically they're providing blood products tourniquets, crikes, among other things that would be basically on the scene rescue items. So should we have a discussion from the panelists, or should I just keep going, Jonathan?
The panelists want to comment at this point. Who would agree with scooping and running, and who would stay and play? Mansoor.
Thanks, Juan. A really, really interesting case, and I can't wait to see where this goes. I think one of my cues, which I'm taking away, it may just be the audio, is the patient is actually in quite, I'd say he's in extremis just by the tone of his voice. And when a young person normally turns around to me and says, I think I'm gonna die, and they're not shouting about it, they're talking in a really calm manner, it really, really raises my alarm bell. So with this and with my military hat on, I think I'd go for the last one, which is what we call the scoop and play, or you call the scoop with ARC. So you're getting this person to definitive care. You're not delaying transfer, but you're doing all you can in your arsenal while you're getting there to try and maintain this individual's perfusion. That would be my view.
And does anybody want to challenge that with an alternative viewpoint? In which case we'll move on. Oh, sorry, Shahin, yes.
Yeah, obviously it's in which system you are practicing and how many of these cases you see on a daily basis. To putting up such a scoop and run and have an advanced resuscitation en route is going to be very hard to get in, like in Europe, where we don't see many of these cases. So having that in a system depends on how much volume you have. So in our system, I would say just scoop and run.
It's interesting that nobody wanted to stay and play, but that may be because there's nobody here from EMS. Okay, I think we'll move on. Thank you, Juan.
All right. So this is what happens next.
He's got crepitus under his left axilla. Feel this crepitus here?
Yeah. Okay, well, we know that one, so, yeah. All right, hold aside. Get your lines, get your blood. I've got a 16. Sounds good, let's hook our blood in. Can you come over to the side?
Blood's working.
We'll keep those pads on, but that's fine. Yep. But his cardiac arrest,
His cardiac arrest.
So as you can tell, they are losing the patient already, and they actually the stay time on the scene was less than 10 minutes. So they are now in the back of the ambulance. You can hear the sirens. The ambulance is running. So let's go to our next poll question, Jonathan.
The next question is, with impending cardiac arrest, priority number 1 will be airway with intubation, breathing with chest tube, circulation, or none of the above. We just need to get this guy to hospital. And for the majority of people, it's circulation, but it's a fairly close thing between airway, breathing, and just getting him to hospital.
You gotta love that. That's the purpose of this. So I would like to hear some challenges on this.
Mansoor, you're up again.
I love this. I love this. This is, guys, come on. I'm going to get fed up of starting to hear my own voice, but I'm going to throw some controversy in here. Juan, I wouldn't do any of those. The first thing I would do for somebody who's got, I believe, a gunshot wound in his axilla, and we've lost him.
In his chest, the left chest, correct. In
his left chest. So I'd actually go back to the basics of what we teach in pre-hospital care, would be bilateral finger thoracostomies to make sure there is no tension pneumothorax going on in either lung field, and then take it from there. So I think I would actually have bilateral thoracostomies on your thing there as well. Is that what you meant, breathing with chest tube, I assume?
Yeah, that's exactly what I meant. So you're saying B before A and C.
Yeah, as a potential reversible cause of shock, because currently you're assuming it's hemorrhage. You don't know if it's a tension pneumothorax which is causing it. I mean, I'll go with the basics and work our way up the ladder.
Fair, fair.
And I'm shocked that I have to agree with Mansoor on this one.
All right, Dr. Coimbra, anything on your side, sir?
Yeah, so not getting into the controversy, but the issue here, I totally agree that in this circumstance, you got to do what you think has the highest likelihood of saving this guy's life. And putting that together with the mechanism of injury, it's very likely that he's exsanguinating his left chest. So, and it's not a tension pneumothorax, but it could be a tension pneumothorax. So I still think that addressing the issue of ruling out a tension pneumothorax would be important. The problem is you put a chest tube in the ambulance and the guy exsanguinates through his chest, you are dead in the water as well. So I think, and it seems that in this ambulance system, you have the ability to resuscitate. So I would probably do both. And while somebody puts a chest tube, I would hang the blood and squeeze it.
All right, fair answer. I like it. So I think we're heading on the right direction. We're gonna go now to the next. So in the back of the ambulance, they decided to start giving warm blood.
You ready for blood? There you go. Holy crap.
And they're infusing it using
I'm watching this bag turn itself inside out. It's going so fast.
it's a live flow device that pushes blood quite fast.
Okay, so we're 2 minutes in from the start.
And now they're asking for a second unit of blood. So let's go to our next poll question, Jonathan.
Okay, so in the presence of hemorrhagic hypovolemic shock, the best fluid to give by EMS is crystalloid, 3% saline, albumin, nothing, or packed red blood cells. And I think, as you can see there, the overwhelming majority would go for packed red blood cells.
So this is very interesting, and I'm glad that the purpose of this is to create controversy and to think out of the box. Dr. Shahin, why not permissive hypotension if such thing exists?
Yeah, so the data on that one from the back in the 80s, 90s from Mattox, penetrating chest trauma, then you have to go with the permissive hypertension. That's at least how we have learned it back in the days. Now, with the data coming out from the Penn, when they gave the FFP, they're talking about going with the FFP first before the packed red blood cells. But I would like to keep this patient hypovolemic until I get to the hospital, because otherwise I'm going to bleed him out by pushing in more fluids into him. And if I have just got one choice to give one fluid, then I would go with the whole blood if you have it en route.
All right, fair. I think Mansoor's itching to answer or say something.
I mean, the patient's in arrest. You can't get much more hypovolemic than that, can you? I mean, that's a pretty low state. So I always think that I personally I like hypovolemia as a bridge to definitive care, providing they're cerebrating okay. If they've got good mental function, you know that you're perfusing their brain and vital organs, I think hypovolemic resuscitation has a place. With regards to this question, I do agree with Shahin as well. The best thing to give somebody who's bleeding is blood, but even better than that is to actually limit blood loss. And I'm going to throw a real can in the worms here. If this was done in any of the British institutions, with a pre-hospital physician provider. I'm going to use the word provider. Shall I use provider? I'll just call him a physician. I hate the word provider. A pre-hospital physician will have opened up the chest already. So I just want to put that out there. The chest would be open.
Interesting.
And then what?
Then we could actually...
Opening a chest is easy, but then what?
Well, what are you going to do if you're saving someone's life? They've either got a tamponade or they've got bleeding from a lung laceration. If they've got a tamponade, you've got your finger on it. You've got hemostasis. If you've got bleeding from lung parenchyma, you can squeeze it. It ain't exactly rocket science.
Yeah, but this because you're a surgeon, you have seen this kind of cases. This discussion was up for discussion in Norway a couple of years back when the paramedics wanted to do the clamshell and right thoracotomy, left thoracotomy, and so on and so forth. And the question always came up, then what? You are standing there.
All you're doing is controlling hemorrhage. Yeah, so our success rate, obviously in the UK, that's why I said physician. So all of our doctors are trained, senior anaesthetists, surgeons, ED. We have a whole spectrum of them, and they are all competent in doing these procedures. And they do this regularly. That's how they do get it. You need to be high volume. And this is where actually your capabilities, competencies come into it. You don't let anybody who's just looked at a video go ahead and do this. It has to be somebody who's competent.
Let me throw out that question out there. Regularly, how many pre-hospital thoracotomies are they doing in the UK, and how many are surviving those?
So survival rate is still about 12%.
Out of how many?
Well, that's 12. It's a percentage, 12%.
Yeah.
I don't know what the denominator is, but your survival is about 12% from these kind of things. But yet again, it is, I don't have to do 100 thoracotomies a year to be able to do it. Once you've done one and you know how to do it, competence and repeatability are two separate things. You could be competent at a procedure after doing 3 of them. You could have somebody who's not competent at a procedure after doing 200 of them. It just depends on the individual, the skill set, and their applicability, I think. That's why people gravitate to these fields to do pre-hospital medicine in the UK, who are pretty keen and pretty competent on the emergent management. Remember, a clamshell is only one of the actual medicinal arsenals they have. They're used to dealing with people with electrocution, mass casualty scenarios. They have a whole array. It's actually a specialist, a very specialist role, done only by a few dozen people, not many.
All right. I think we're heading on a lot of discussion. Let's then head to the next. This is the patient already still.
Ketamine's given. Let's drop our section. You ready for that? We'll get him intubated after we open his chest wall. You ready, Joe? Downward. There you go. Perfect. Good enough. All right. Then still pop. Okay. Yep. Pull apart. Hard. All right. Significant hemothorax on the left. All right. Put your finger in there and just get it as wide as possible. Right. Gotcha.
So let's go to our poll question. This gentleman, they did a finger thoracostomy without chest tube on the side of the injury. And please as a reminder, the patient has been getting blood during this time. And let's go to our poll question.
This question is, as part of advanced resuscitative care, EMS should be properly trained and competent to perform crikes, finger thoracostomies, point of care ultrasound, blood transfusion, or none of the above. They just need to be able to drive the vein very quickly and get it to the hospital. And here we go, the vast majority of the participants think that the appropriate thing is for them to be trained in finger thoracostomies. Of course, the poll system here for this question only allowed you to make one selection, so you could perhaps want them to be trained in all of the above. But the most important one, or the most useful one deemed by the audience today, is finger thoracostomies.
So, and that's, I agree 100%, Jonathan. I think we should have all of the above before the none of the above. And so for this case scenario, and I would like to ask Dr. Coimbra, in the United States system, do you see future for EMS to start doing finger thoracostomies? There's a couple of institutions doing it, but it's not adopted nationwide. What is your take on that?
Yeah, I'm really impressed with what you are showing because I don't see this being widespread in North America. The country is too big. The pre-hospital systems are too diverse. We have huge rural areas with low volume, so proficiency in those procedures would be a problem. We have long transport times in high populated metropolitan areas. In the system that I know well, in the San Diego system, which is a pretty advanced pre-hospital system, these procedures are done only in the helicopter by highly trained nurses and paramedics. As you know, we don't carry physicians in the ambulance in the US in most systems. So and there is a huge issue of liability in the US as well that needs to be overcome to allow people to do this in a widespread manner.
All right, Dr. Shahin, Dr. Mansoor, any other points at this, on this patient care?
I think I totally agree. I think the basics of this is I think a finger thoracostomy is a life-saving procedure, which should be taught. The surgical airways can become quite tricky, and I think you need to be able to do a lot of those. And yet again, with the POCUS, you're only as good as the number of POCUS you do. The more you do, the better you get. And the moment you take your foot off the pedal and you haven't done them for a while, you de-skill quite quickly. So you have to meet competency with exposure. But I definitely think finger thoracostomy is a life-saving maneuver which should be taught, because at the end of the day, you're only doing a finger thoracostomy because the patient is dying in front of you. And I was once told you can't kill somebody who's dead.
All right. Anyone else, or we can go to the last video clip of this case? All right. So
I don't think he's got an oxygenation problem. I just know that when we intubated, he'll rest.
99/60.
Perfect. So we got blood going into both.
That one going over. Keep it on.
Okay. We got another blood pressure going, 100/63. I'm convinced that with the continued infusion of blood products that he will hopefully, and if there is all suspension pneumo, he won't arrest. So one more blood pressure.
All right, so they just talked through the whole thing, Patrick, that you gave us earlier. He's going to arrest unless we get his blood pressure up. And this is he went from 80 to 99 to 10 something to 119 immediately for pre-intubation. That's with about 2.5 units of whole blood.
Okay, let's go. Let's push this to Cinepol next.
Sucks.
Yes, they do.
No, sir.
All right.
I got 104.58 stats with 100%, heart rate 82.
All right, epiglottis. Still a little deeper. There you go.
All right, there we go.
all right, so as you can see, you can tell there was some kind of coordination where the plan was to get the blood pressure higher with blood transfusion, decompress the chest, and then intubation and protect the airway. So let's go ahead, Jonathan, with the last question of this case scenario.
And the final question, based on this case scenario, has your current point of view changed regarding advanced care or CAB? You've got me with that one.
Circulation first, followed by airway and breathing, or
Yeah.
traditional ABC.
Yeah. And the poll shows probably about a 50-50 split.
All
so
right.
Some minds and others you haven't.
Well, that's perfect, because like I always tell my residents, when I hear no, that means that 50% of the chance it will be yes later. So that's a good start. I think that is something that we still need level 1 evidence to see if circulation should go first in this specific group of patients, not for all patients, but in this specific group of patients. Maybe more research with level 1 evidence is still needed. I will open up to the panel now.
Mansoor, you're keen
Yeah,
to go.
sorry, I thought I put that. So, Juan, I want to disagree with you there. More level 1 evidence required. I mean, I know for a fact it's the old parachute trial. There's no level 1 evidence that a parachute will save my life if I jump out of a plane at 2,000 feet. But I tell you what, I'd rather want it. Yet again, if you think about the whole purpose of the big bleeding first, we've been practicing that in the British military and advocating it since the early 2000s. And we've shown it works, because if you look at the amount of deoxygenating time, well, you've got about 3 minutes before you start to drop your SATs and you start to drop your oxygen levels. And if you do secure your airway, you require your circulating volume to transport that molecule of oxygen to your end tissues. Because if you don't have that volume intravascularly, the oxygen molecule is just going to sit in the alveolus, go, right, I've got absolutely nowhere to go. So I'm a big advocate, and have been for, God, ever since I started training, for the big C. It's why we become trauma surgeons. It's why we turn off the tap first before we secure anything else. And until you've got control of that big C, I think the rest of A, B, C, D, E is a bit of lip service. But that's why we do horizontal resuscitation nowadays, where everything happens together.
Nice, very interesting concept. So parachutes, I like it. All right, anyone else?
Yeah, so Juan, I just have one question about this case. How far away from the level 1 trauma center was this case? What was the overall transport time if they had chosen to scoop and run?
That's a great question, Raul. This case actually was a 35-minute transport time.
Okay, perfect.
Very good point. Patient arrived to the hospital straight to the OR because the output was ongoing on the chest, and that he ended up having a lobectomy on the left chest, thoracotomy, lobectomy. They did not stop in the emergency department. So next case scenario is actually different. It's blunt trauma, and it is a forklift fell over a patient pelvis. And this happened after Hurricane Ida. There's been a lot of what is called weekend warriors in Louisiana trying to do their own things and fix their properties. And this gentleman was actually working and trying to get a forklift off the bed of a truck. And that's the forklift. And that forklift basically landed over him. EMS report that this was a 45-year-old male with crush injury to the pelvis. Initial systolic en route is 60 over pulp with a heart rate of 145. Point of care ultrasound was inconclusive due to patient's body habitus. The patient is diaphoretic and thirsty, and he's saying, I am dying. Where do you go when they arrive to the hospital? And I do believe we have a poll question, Jonathan.
We do indeed, and it's that same question. Where do you go when the patient arrives in hospital? To the emergency room, to a hybrid emergency room? You bypass the ER and rush to the 4th floor operating room? You go to interventional radiology, or it really doesn't matter? And it looks like we're all spoiled, and over half of us have a hybrid emergency room that we would take the patient to.
So obviously, I will let, if there's any other comments, I will let the panelists discuss.
I want to know who has a hybrid emergency room in this webinar. Except if there is no Japanese folks here, who has a hybrid emergency room?
We will have it on next summer, sir.
Emergency room or a hybrid OR?
No, hybrid emergency room with the gentry CT.
Well, that's not a hybrid emergency room. You need to have stop the bleeding capabilities. You need to have IR in your emergency room.
Yeah, and then our friends with Reboa and interventional radiology, they can do their stuff in there if they want to.
So here's an interesting one, which I can never quite figure out. I think, first of all, I think in developing systems or even mature systems, there should be a process where I look at this person. If EMS tells me that is the parameters, that person should be bypassing emergency room and going straight onto the operating room. And the reason why I say that is the best resuscitation room in the entire hospital, I still believe, is the OR table. Now, as Prof. Coimbra has mentioned, unless you're in Japan, where you can turn up into an ER, where you have fluoro, CT, I mean, everything is there, which I believe is trauma Disneyland. I'll be absolutely honest with you. To try and get that amount of resources in one place and actually in multiple rooms does require a lot of finances. In the absence of that, I think you should be ready to actually take this person straight to the operating room, because they may need a big cup in the absence of, say, Reboa or any other available utility, if that makes sense. And one of the reasons why I want to put the caveat in about the Reboa is I'm a firm believer that Reboa does have its uses somewhere, it will have, but I always get told that pelvis injuries are the big ones. They're the big ones that Reboa is really good for. But if you look at catastrophic pelvic injuries, where it does play a big role in, you're still talking about a zone 1 deployment, because there's up to an 80% incident of intra-abdominal injury. So even if you try and place a zone 3 Reboa, you're going to make intra-abdominal bleeding worse. So you know what? Old-fashioned surgeon, take them to the operating room and get your scalpel out.
All right.
You're going to disagree with me.
No,
I thought Prof. Coimbra was ready there. He was poised. He nearly said something. Shahin, come on.
I would take this patient directly to the OR. But once again, we do our intervention radiologists in our OR here too. So,
okay. So we are in a very poor system in Louisiana. We don't have that capability of having an emergency room OR in the same place. So this patient arrived to our emergency department. We did a quick chest x-ray. There was no white mediastinum, nothing, no signs of hemorrhagic cues in the chest. The pelvic x-ray showed basically an open book pelvic fracture. So at that point, the patient was in the emergency department, where we were infusing immediately whole blood into the patient as soon as we got that first systolic of 80. We are using, as part of the protocol, 2 grams of calcium with 2 grams of TXA on arrival for patients that require any single unit of whole blood. We put the pelvic sling in the emergency department and reduced the pelvis, and we place a partial Reboa catheter. And this is basically the 2 A lines in the partial Reboa. The blood pressure on top is a blood pressure above the balloon. The blood pressure below is a blood pressure below the balloon. And this is our patient. So based on these findings, I would like to go to our next question, Jonathan, and last question for this case scenario.
The last question is, the compliance percentage of damage control resuscitation interventions in the USA are greater than 90%, around 50%, less than 30%, or it really doesn't matter because DCR doesn't work? And I think, given the fact that most of the audience are European, this will be quite an interesting insight. I'm not sure whether that's the correct answer, but I think most people have probably just gone for the typical multiple choice question response of, if you don't know, go for the middle one.
And that is what? That is 30%?
That's 50%, sorry.
50%.
About 50% of the audience think it's about 50%, 40% say less than 30, and 12% have great faith in that shining edifice that's the United States, so they think it's over 90%.
Yeah, so it's a very interesting topic, and actually we are evolving more and more into knowing what is the true compliance in the United States. For one-to-one resuscitation in our studies and previous other studies, what we documented is that we are doing quite well in the 88 to 90% compliance in as part of the DCR. But regarding tranexamic acid, regarding Reboas, regarding TEG use, regarding even pelvic binder use, we are in less than 30% compliance, and that's from multi-institutional analysis. So there is still, I think that there is still room for improvement, specifically in the United States, but those numbers are basically very repetitive in different kind of studies regarding damage control resuscitation. This gentleman had a zone 1 first initially. After we got that pelvic x-ray, we went to zone 3. And the patient underwent interventional radiology assessment, and they identified the bleeder and embolized it, and Rebo was removed. The patient did actually quite well after that. So just quickly, I would like to then, we presented this kind of analysis called impact of time to surgery and mortality in hypothesis patient with non-compressible torso hemorrhage, a AAST multi-center prospective analysis, where basically what we decided to do is to look at the experience from multiple institutions regarding damage control resuscitation. And from our previous analysis, where we look at 800 massive transfusion protocols, we identified that the use of tourniquet and the use of whole blood were the only ones that actually were providing some kind of benefit. But the mortality overall in a 12-year analysis, we were still in the 47% mortality on all comers that needed a massive transfusion protocol. This is not an isolated study. This study basically goes side to side to Dr. Harvin analysis, multi-institutional on the mortality for damage control interventions, where basically they demonstrated that the mortality have not changed in the last 20 years, ranging from 40 to 46%. So in our current situation, we understand that non-compressible torso hemorrhage is the leading cause of potential preventable death, accounting for 30 to 40% of trauma-related mortality. So time is critical, as many deaths occurs in the first 30 minutes in patients with non-compressible torso hemorrhage. Because of that, we need to look at our system. Our current system of scoop and run, which basically has been for more than 20 years, have not really changed the mortality outcomes in this group of patients. Then once the patient arrives to us, we keep running. We keep running from the emergency department to the CAT scanner, to the OR, to the interventional radiologist, and then back to the ICU. So because of that, we wanted to look at the outcomes from a multi-institutional analysis, and we hypothesized that shorter time to surgical intervention for hemorrhage control will decrease mortality in hypotensive patients with non-compressible torso hemorrhage. So this was a AAST analysis, basically from May 2018 to December 2020 of all hypotensive patients with isolated non-compressible torso hemorrhage. Hypotensive was the inclusion criteria less than 90 millimeters of mercury. So we basically had a total of 262 patients, of which 242 met inclusion criteria. The cohort analysis was very similar between blunt versus penetrating, 48% versus 51%. We had a total of 20% of patients that were non-survivors and 80% were survivors. Remember, the cohort is non-compressible torso hemorrhage. And obviously the non-survivors had a higher a new injury severity score, higher chest AIS score. Vascular injury was definitely higher in the non-survivor group. In the non-survivor group, they basically had a lower systolic blood pressure with higher incidence of shock index and basically more coagulopathy. When we look at the procedures, and this is what is very interesting, and I'm glad we had this great discussion of C versus A as part of the ABCs. The non-survivors had actually a higher rate of intubations and chest tube, with obviously an increase in mortality. Imaging studies prior to surgical intervention, obviously the non-survivors had way less imaging studies, and the reason being is these patients were rushed through the system to the operating room. when looking at intraoperative findings, the non-survivors require way more blood utilization products, more tranexamic acid use because of their shock state, persistent shock state, and higher incidence of damage control thoracotomies. So when we look at the essence of our analysis, it was all about time. And it is important to remember that, as is being described by Holcomb and others, that the peak time of death from non-compressible torsal hemorrhage is in the 30-minute window. For those of you guys that still believe that there's such a golden hour, I just put this in my presentation, but really I don't pay attention to that because people are dying way before that. For this analysis, when we look at all the institutions, it was interesting that the average transport time was 28 to 30 minutes, and there was no difference in transport time by the pre-hospital service in patients that were survivors versus non-survivors. No difference. Once the patient arrived to the emergency department, then you can see that the non-survivors were basically rushed through the system with 7 minutes less than the survivors in the emergency department, and obviously less than 10 minutes, more than 10 minutes difference in reaching to the OR. So when we look at the whole concept in United States, it took 74 to 88 minutes in this analysis to get non-compressible torsal hemorrhage patients from the scene to the surgical suite. In our Cox regression analysis, we were able to identify, as many other studies have demonstrated, that age, new injury severity score, and initial shock index were definitely factors affecting outcomes in mortality. And obviously, when to my surprise, in the multiple variable Cox regression, showed shorter times from emergency department arrival to OR start was not associated with improved survival. So what this means, and this is just, and I'll get back to that statement, but this is a compliance analysis that we did from the 15 institutions that collaborated in our analysis. As you can see, balanced resuscitation compliance is quite high, but then obviously the use of other resources is quite low, less than 30% for all of them. So in conclusions, the patient who expired arrived to trauma center in a similar time frame as did survivors. Many patients with non-compressible torsal hemorrhage expired before they can realistically reach an emergency department and operating suite, and obviously long before the favorable golden hour. This suggests that even expediting a critical ill patient through the current trauma system is not sufficient time to save life from non-compressible torsal hemorrhage. And obviously, adaptation or incorporation of advanced resuscitative care should be contemplated. So as we demonstrated in our analysis, it takes 74 to 88 minutes to get a non-compressible torsal hemorrhage hypotensive patient from the scene to the OR. As we previously discussed, most of these patients' mortality occur in the first 30 minutes. And as you can tell, it takes on average 30 to 28 minutes to get the patient from the scene, ambulance getting to the injured patient, to our system in the United States. So let's talk about what can we change, or thinking out of the box. In an analysis that we presented at AAC this year as well, we look at the time of effective EMS contact. That means the time that EMS first touched the patient to the time they arrived to the emergency department. And we identified that that time, based on the Trauma Quality Improvement Network, ranges close to 33 minutes overall time. And there was a mortality of 34% during those 33 minutes where there was no advanced resuscitative care. And for that reason, we basically are proposing to maybe move that pendulum of care of the emergency department, and maybe put some of those things that we do in the emergency department early in the first touch with the patient when the EMS first arrive. And this is what we call the SPARC team, Selective Pre-Hospital Advanced Resuscitative Care, which basically what it does is just move that pendulum where the patient is injured and they start taking care of the patient on the scene without delaying transfer time. And that's all I have. I will pause at this time, and thank you so much for all your time. I will stop share at this point.
Thank you, Juan, for two great case presentations and a very good thought-provoking presentation there. I'm going to open it to the members of the panel to comment if they dare.
So thanks, Juan. That was a cracking study there. And well, it just shows you time to definitive care is actually the most important thing. Now, as Prof. Coimbra probably got fed up of me over the weekend, I personally believe that concept of prolonged field care is a bit of an oxymoron. You shouldn't do prolonged field care because that is actually suboptimal medical care. It is a commitment the government, military, whatever make to rationalize or orchestrate medical services so they're providing the maximum amount of care for the many given the resources that they have. But what your Spark team there is almost insinuating is a bit like a HEMS team, aren't they? An advanced trauma team going out. Is that correct? Am I getting the right framework there?
That's in the contemplation, and we still haven't figured out who is that right person to deploy or to have in that satellite ambulance system. Is it going to be a medic? Is it going to be a trauma surgeon? That's something to further discuss.
I think one of the big problems, which is slightly different in the UK, is we're a relatively small island. If you look at, say, the USA, even Sweden, where Shahin is, you've got hospitals quite far away from some of these areas. So you have huge evacuation timelines. Now, it isn't possible to have a level 1 trauma center within 30 minutes of every single casualty in the US. It isn't going to happen without having the helicopters and all that. But what you can do is go for those easy wins and try and mitigate. You know what I mean by the easy wins? Try and actually do the basics well. And if you do enough of the basics well, you have a greater impact nationally. Am I making sense in my theology there? Not going for the major high interventions like everybody should be able to do Reboa, ultrasound guided lines, but do the basics of care well. Apply tourniquets, you know, as you say, do the finger thoracostomies. Try and get a pulse back to the person en route, and you may be saving more lives with that group of people than that highly specialized unit, which will maybe save 4 or 5 lives a year.
Definitely agree.
Shahin, are your thoughts on that with regards to EMS and stuff in Sweden? Because I know you've got geographical and snow limitations.
Yeah. No, I agree with you. The thing is that the penetrating traumas are happening in the urban centers, and then the hospitals are quite near. And those patients that do have longer transport time, getting our medics with the anesthesiology or trauma surgeons to them would take too much time. So I think that system is not going to work here at the moment. And I still would root for the penetrating trauma, which I know by our data is happening in our major cities and usually downtown, which most of our hospitals located. Taking them the fastest way to the hospital is where we win.
Mm-hmm.
I just want to make a couple comments as an introduction to my talk because, you know, one, first congratulate Juan, excellent presentations, good research that Juan is doing for the last several years on DCR and now looking at the intersect between pre-hospital and hospital care. I'm glad to see this paper that he presented in the WST that will certainly be published in the Journal of Trauma because like everything in medicine, old things come back again. And what he really found out in his paper is what we've been saying in San Diego since 1984. And I will show it to you today with pretty good data as well. So if the pre-hospital transport time is fixed, I totally agree that you need then to bring more resources to provide life-saving procedures in the pre-hospital system. But that alone is not going to have the impact that if you also had an in-hospital component, which is to have an operating room resuscitation. And this is what I'm going to show to you. Now, why Juan and his group didn't touch in the OR resus issue, and they said that moving faster to the operating room had no impact in the study? because 14 of the 15 hospitals that were included in that study don't have an OR resuscitation protocol. So obviously it's not going to have an impact. So it's skewed. It's completely, there is a huge selection bias on the trauma centers in that study. There is only one center in those 15 that has an OR resus, which is the UC San Diego Trauma Center. So I wouldn't throw the OR resuscitation protocol as a significant advancement in improving mortality in the trash at this point, because we need to fight our hospital administrators to gather those resources, and that's tough. It's easier to change the pre-hospital system than to change the in-hospital system, because that includes discussions of millions and millions of dollars. But I think they are in the right track. But I still believe that this problem will be solved when you address the pre-hospital and the in-hospital system, bringing resources to patients or bringing patients to where the resources are instead of running around on both ends.
Well, do you want to comment on that?
Oh, no, I'm delighted that Dr. Raul Coimbra was so kind. I agree with Dr. Coimbra. I do believe that there's a lot of politics within the infrastructure of the hospitals, specifically in the United States. And I think that one of the things that we can provide is from the lecture that Dr. Coimbra is going to do, take that message to our trauma centers to incorporate better, not only better OR resuscitation guidelines, but maybe through what is called the verification committee, making it as a target for you to be certified as a level 1 trauma center to include proper resuscitation of selective group of patients. I think that it's multiple factorial, and it will take a lot of politics, but it's definitely doable. And regarding the pre-hospital system, I think that it is crucial that all these findings are presented and demonstrated to them and get them more on board, so they will not feel like they are just a transport service. They are part of the team.
I think teamwork is always very important, and we've given Raul an enormous build-up now for his presentation, so I will hand over the screen to him. Raul.
Thank you so much. This has been a terrific webinar, and I think that those that are missing it should be able to watch this later on the taped version, because I think this is one of the best, and I applaud the team putting this together. So I'm going to talk to you about this concept of operating room resuscitation, which is not rushing patients to the OR and bypassing the ER exclusively, but it's a much more involving concept. So let me give you some background. So delayed transfers to the operating room has been considered a cause of preventable death in trauma. We have several papers from the late 80s and the mid 90s that came out from San Diego showing that. Several institutions now have put protocols into place to improve transfer times to the operating room, but that is not enough, and you need a comprehensive operating room resuscitation environment to change outcomes. And few trauma centers have this policy for resuscitation in the operating room. So let me give you some background. The trauma center that I was honored to be part of and to lead for more than 2 decades, UC San Diego, is a level 1 trauma center and instituted an operating room resuscitation protocol in 1984. Dave Hoyt did it. And this was based on triage criteria that was created for patients who were believed to benefit most from this protocol. Obviously, at that time, we didn't have the ability to know DCR. We didn't have the ability to use whole blood. The paramedics were doing basic things during transport. So this was the best we could do at that time. And Hoyt and others developed 5 criteria for OR resuscitation. CPR in progress after traumatic arrest was the first one, but perhaps the one that's the least important. Persistent hypotension, systolic blood pressure less than 80, unresponsive to fluid resuscitation during transport, what we now fancily call non-compressible torso hemorrhage. Amputation or uncontrolled external hemorrhage requiring immediate operative intervention, so traumatic amputation primarily. Penetrating torso injury with hypotension, just the case you saw that Juan presented. And difficult airway or impending airway loss, particularly in penetrating injuries to the neck with expanding hematomas. At the time, we believed that those 5 patient categories would benefit from resuscitation in the operating room. Not necessarily an operation, but resuscitation in the operating room. So how does this work? So you are sitting in the trauma center, your trauma room, your nurse, whoever receives a call from the EMS and gets a report. And they basically say, we are transporting this guy to you. The trauma resuscitation nurse at UC San Diego decides, based on those 5 criteria, if the patient meets one of those to be an OR resuscitation case, and decides where the patient goes. The medics are trained in our catchment area to either go to the operating room or to the trauma bay, which is not in the emergency department, by the way. We have a freestanding trauma center in San Diego, and those patients go straight to the trauma center, and we bypass the ER completely. This is different. We bypass the trauma center completely. And if a patient is an OR resus, the patient has to have a 5-minute ETA. You can't set up everything you need, although most of it's already set up, if the ETA is less than 5 minutes, but most are greater than 5 minutes. How is this done? Well, once a decision is made that somebody is going to be an OR resus, and there is less than 5 minutes, that decision cannot be changed. So there is no confusion because the team has to move from one site to the other. So the team still runs to the right spot. It is difficult, it's too difficult to remobilize the entire staff once it has been set into motion. So once we make that decision, the whole team assembles in that right location. So this is our OR resus. Used to be a large OR. You don't see anything fancy here, but you see fixed X-ray capabilities at the top. And you see, the monitoring system at the head for anesthesia. You see 2 sets of monitors, one that faces the anesthesiologist right there, and one that faces the trauma nurses here, because the trauma nurses respond to the operating room resuscitation. As I said, the whole team responds as if we were in the trauma bay, but here we are in the OR trauma bay. So this is really a trauma bay inside the operating room, and it so happens that you can perform an operation there. So sort of the Japanese concept, but in the operating room. And here is the rest of the room. So you can see you have the packs there ready to be opened by the scrub nurses, who stand on this right of the room, on this side of the room, on the right side of the room, but the resuscitation nurses, the rapid infusers, everything else, the cell saver, everything else is on the left side of this room. So this is an OR that's prepared to either be a regular OR, if you want. We never wanted it. We always use this OR exclusively for operating room resuscitations, or it's a trauma bay inside the OR, whatever you want to call it. So basically, this is the system that we use for resuscitation in the operating room. Eventually, the police walks in there. We have an OR desk here. The OR table is there with the scrub nurses. We have an X-ray tech. We have Doc 1 taking care of the patient, Doc 2 to help Doc 1, 2 nurses, 1 on each side of the bed, the resuscitation nurses. We have a runner to go get the blood, and now we have a fridge in that room with blood. We have all the carts here, and we have the only difference compared to the trauma bay is that we have 100% anesthesia presence because you are in the operating room, and eventually you may need to get an airway or perform an operation. So what are the exceptions to this protocol? Isolated penetrating head trauma, so gunshot wounds to the brain with cardiac arrest, we don't take them there. And if there is more than one patient arriving at the same time to the trauma center, so if the EMS says I have 2 gunshot wounds to the chest, just like Juan showed to us, then, and we only have 1 OR resuscitation, then both of those patients will be resuscitated in the regular trauma base because we don't have enough people in-house to split the teams, or we don't have 2 ORs to provide the same quality of care. This is a node study that proves that old things come back. This was published in Archives of Surgery, now JAMA Surgery in 1989 by Dr. Hoyt, Shackford, and others. And basically he showed that with in-house surgeons available, enthusiasm for direct transfers from the scene to the operating room has developed in many institutions. And basically they looked at 323 patients taken directly from the field to the operating room over a 4-year period. And this constituted 6.9% of the trauma activations. And the indications were those that I showed to you. And basically, they concluded that cardiopulmonary resuscitation for patients with blunt trauma was not accompanied by survival. So that was an indication, but as I said, not a very important one. And waste is valuable OR resources. Patients with pre-hospital hypotension unresponsive to fluid resuscitation indicate the need for rapid surgery, so those were good candidates. So the non-compressible torso hemorrhage. Blunt injuries with hypotension infrequently undergo an operation in less than 20 minutes and can be resuscitated in traditional areas. So if you don't have all the resources, you can exclude those patients. We never did. We took them all to the operating room. And penetrating injuries to the chest and abdomen with hypotension obviously are the best indication. And this can be done with field communication and it's accompanied by enhanced survival. So that was the first study. Then the second study was published basically a decade later and concluded that field triage criteria are able to reliably identify patients who required immediate major operative intervention, and direct admission to the OR results in a more timely initiation of operative therapy for patients requiring emergency surgical procedures. So if you are looking for a squeeze some time into this continuum, this is what you need to do. Why? So analysis of the first 10 years of the protocol showed that patients had improved survival compared to probability of survival at the scene or at admission. Patients with penetrating injury and low blood pressure had the greatest improvement in survival. And then we looked very carefully at our data in heart injuries, aortic injuries, and vena cava injuries. And collectively, these 3 lethal injuries, we observed a 20+% higher survival in the operating room resuscitation cases compared to patients going to the trauma bay first. Obviously understanding that we are comparing oranges to apples because those patients that go to the OR directly are much sicker, but yet their mortality was 20% decreased compared to those that had similar injuries but came in more stable and therefore didn't meet initial criteria for operating room resuscitation. How often we do this? It's about 4 to 5% of all trauma activations. So this is not an everyday thing, and it's a very expensive resource. And I will leave that fight for you and your hospital administrations. We have been able to keep that process going for more than 30 years. I'm going to skip this and show you some survival by injury type. So again, in penetrating injury, the real benefit was for those that suffered gunshot wounds. And then I want to end with this paper because, you know, people usually doesn't pay attention to this paper, but this is a very important paper. This is our analysis of 20 years of abdominal aortic injuries, traumatic abdominal aortic injuries, primarily penetrating injuries. And this is the paper that showed that despite advances in fluid resuscitation, operative strategy, and transport, the mortality of this injury is still very high. And when we took those patients to the operating room, here it is, resuscitation in the operating room, we offered significant survival advantage. And here, this is the data. Those patients with abdominal aortic injuries that were resuscitated in the OR had a 40% mortality. This is a phenomenal result. 60% survival in penetrating injuries to the abdominal aorta is remarkable. The mortality, if you are resuscitated in the trauma bay, consider that you are in much better shape if you go to the trauma bay, was 78%. So I think this is the most compelling data. Look, these people were sicker, their pH were lower. Now, time to laparotomy in these guys were 10 minutes. Whereas if you go to the resus room, there is always an x-ray, there is always somebody trying to get a second IV, there is always somebody trying to turn the patient. And we don't appreciate how much time we spend there. So we spend 30 minutes in the resus room. And the time to bleeding control overall for the OR resus was 13 minutes. So between the decision to cut and put your finger in the bleeding vessel was 13 minutes compared to 39 minutes if you go to the trauma bay, then you go to the resuscitation, then you go to the operating room. And then when we did the multivariate analysis on this study, operating room resuscitation was obviously an independent risk factor for survival, whereas trauma room resuscitation was an independent risk for mortality. So really, really powerful data that should be reproduced if we had more centers engaged in this protocol. What matters with this? Well, obviously time to bleeding control. There is an anesthesia team that provides airway control 100% of the time. The decisions are clinical. You didn't see anything fancy. That's not a hybrid room. You didn't see a C-arm or a sliding CT scanner in and out. Those decisions were clinical. We only had an X-ray in the early years and then an ultrasound in the late years. And you need to use your clinical judgment. And in penetrating injuries, what matters is finger on the hole, packing, blood availability, and a clamp in a bleeding vessel. Everything moves faster in the operating room. There are now other centers that have adopted this. This is a study from Portland, Oregon, suggesting that direct transport to the OR decreases mortality. This is not quite having a resuscitation room in the OR, but it's close. The same group in Portland, Oregon, expanded the indications that we had. Now they have a long list of indications suggesting that, you know, if the resources are available, you can take more patients there. But you need to understand that not everyone that goes to that OR is going to get an operation. And that's what you need to explain to your hospital administration, that it's not just going to the OR because you need to operate on someone, but it's going to the OR because the patient needs those resources and how fast you can utilize those resources to save a life. Obviously, this is the dream. This is the Osaka Medical Center, Osaka University hybrid ER. And the Japanese actually follow the same concept. Bring the resources to the patient, bring the patient to where the resources are, and they actually do perform operations in this room as well in the emergency department. But that is because in Japan, they cannot have access to the main ORs. Trauma surgeons rarely have access to the main OR when hospitals are inundated with cancer and other transplantation and other types of general surgery cases. So they had to adapt. Just like we did in San Diego, we had to adapt. They had to adapt and make their ORs, their ER suites, OR suites. And now they made them hybrid ER suites. But the concept is the same. Take the patient to where all the resources are and where you can provide comprehensive care. And with that, I'm going to finish, and I hope I simulate some controversy and discussion here.
Thank you, Raul, for that great presentation. I think it has been an excellent webinar this evening, and I'm looking forward to somebody challenging you or coming up with some contrary views. but I don't see anybody wanting to at the moment. Mansoor.
I agree with Prof. Coimbra totally, so I'm not going to contradict him. Totally agree with it. And I think he's answered Prof. Duchesne's earlier thing about, you know what? Catastrophic hemorrhage control is the key. Time to getting the person to the OR and stopping that bleeding. It's not just the bleeding itself, it's the whole inflammatory response, the coagulopathy you get along with it. The sooner you stop it, the better it is. And that is phenomenal work. Within 10 minutes to have somebody in an OR and operated on, and that survival rate for a penetrating aortic injury is quite astounding. So boss, really impressed with that.
Yeah, I want to, first of all, thank the whole committee for allowing us to present all of our personal opinions and scientific data. And I would like to, my question to Raul is, or it's not just a question, it's maybe how can we, I know that you said you need to bring this to executive and let executive decide with you the politics, but if the room is used only 5% of the times, why we don't then just use that room to just bring all hypotensive patients to that room? Is that part of the protocol? All hypotensive go to that room, Raul?
Yeah, so as you know, when you look at collectively at any level 1 trauma center in the United States, with very, very rare exceptions, the number of patients that arrive in shock with a systolic less than 80 is about 7%. So this is, you know, you can look at TQIP and NTDB, it's always every year after year is 6 to 7%. So our utilization was pretty close, was about 4 to 5%. So we took most of those there. The ones that we didn't take there were the gunshot wounds to the head that come in hypotensive that we excluded, and people that had CPR in progress greater than 15 minutes pre-hospital. But everyone else that was hypotensive, whether penetrating or blunt, we took there, knowing that 60% of those may not require an operation, just like the pelvic fracture case that you showed. So it's hard to convince the hospital administrators that you're going to have a room sitting there. But when you show data like I showed the aortic data, and we collectively put together for the hospital administration when they were challenging us to take that room away several years ago, we put together the vena cava and the hearts. And I said, you know, if your wife, I said this to the CEO, I said, if your wife or your son is stabbed in the heart or shot, you want him to be treated in the ER of your hospital, in the trauma bay, or in the OR. And if we don't have the OR resuscitation capabilities, and I tell you that your son has a 40% higher chance of dying, what do you say? And you know, those are tough conversations, but eventually you got to have it to preserve those resources. This is about the results. And you know, it's exactly like your study. You know, you are showing that if you bring those resources to the pre-hospital system, undeniably you're going to improve outcomes. It's the same situation here. Who has the ability to fight those results publicly? You know, this gets on the press, this gets on the professional organizations, this gets in the scientific journals, and you can't deny it. So I think we need to put our foot down and improve both the pre-hospital, shortening the pre-hospital time and bringing resources there, and shortening the time to the operating room by resuscitating people in the OR.
I think, Raul, that you have silenced all the opposition with such a fantastic presentation. I think everybody is now going to go and try and rush their patients straight from the front door to the operating room, provided they meet those criteria.
Yeah, you know, Jonathan, you need a little bit of organization to do this, because I don't know if it became clear, but in our system in San Diego, the whole team moved, and the whole team means the trauma nurses, the resuscitation nurses, you know, the runners. We had the same team. The people that you work with every day in the trauma base, you had in the operating room. The people of the OR stand stood on the side waiting for us to say, we are going to cut. And then they set up the instruments and open the packets, and the anesthesiologist put the patient to sleep if the patient was not already intubated. But it is important that you have the capability of communication and move the whole team. If I go to, in the current hospital where I'm working, if I do this today, I won't have any difference in outcomes. Because if I just show up in the operating room with a patient like Juan presented, and my trauma nurses are not there, the blood bank capabilities are not there, the runners are not there, the people that know what I do every day, that what I like, the instruments that we need, they're not there every day, it's not gonna happen. So it requires a lot more organization in terms of what the trauma team is and where the trauma team goes to. We did the same for interventional radiology. Every time we go to the interventional radiology, the whole team goes to interventional radiology. The nurses resuscitating our patients while a pelvis is being embolized is not a radiology nurse, is a trauma nurse. And that is what makes the difference.
Yeah, if you haven't got the right team, you might as well do it in the car park.
That's right.
I mean, further to what Prof. Coimbra said there, when I was at St. Mary's, we implemented a rapid resus transit protocol. So for the sickest patients, when you had the EMS highlight that this person is coming in shocked, hypotensive, and they looked like they had blood spiked and were really tanking, we just had them rapidly transiting, literally like Monopoly, go past, go, and straight into the operating room. And that way, as Prof. Coimbra said, we, rather than waiting for the incision to happen, the theatre team were prepped, the resus team were there, so it was a seamless transition. And many, many times, we kept the trauma team leader, which was a pre-hospital, an emergency department consultant or an anesthesiologist or a surgeon, whoever it was, come in theatre. So while the surgeon is controlling the hemorrhage, the anaesthetist throwing in the blood, you've got somebody who has overview of the whole area. And once we got control as surgeons and the anaesthetist, we used to look up and say, right, we've got a bit of control now. Thank you very much for your help. So it's getting the right team members in. And the team members are those who do it frequently, not who just do it occasionally. I think your most important resource is your experienced staff, and nothing mitigates against that.
Do you think that this is something that has a place in Europe and UK, given the fact that the vast majority, over 90% of the trauma that we see is not penetrating, but blunt?
I'll be honest with you, but penetrating trauma is really easy to manage. Invariably, they need some degree of cut. Blunt trauma is where you have, oh, what do we need to do them? Do they need an operation? I don't think the same trauma paradigm can work even in Europe, in all the same countries. In UK, we're a smallish island compared to the rest of Europe, different topography, different resources. Trauma has to be implemented depending on the resources and the framework you have in each country. But the basics remain the same. If you want to stop somebody bleeding from hemorrhage, well, you know what? You have to turn off the tap pretty quickly. So you stick with the basics and you build the system around the basics and what the country allows you to do. And I don't think you can go wrong. Thoughts, gents? Is everyone passed out? Oh, did everyone just agree with me? I've got to type this as a red letter day. God, I've had all the profs agree with me. Tick, 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 all done.
We have a question, Raul, that what percentage of patients didn't need operative treatment in the OR resus group? I think you answered that. It was about 60%, wasn't it?
Yeah, overall, 60%. It's about 65 to 70% on the blunt and about 25% on the penetrating.
Also, just to go back to what Prof. Duchesne and Prof. Coimbra have just mentioned, is the key thing here is always you have to be dynamic in making your decision. If a person comes into the operating room and they're semi-compromised, you don't want to sit there and say, I'm going to give them an hour or 20 minutes. Make a decision. Say, all right, does this person need the OR or the CAT scan? And then remember, your decisions can change. If by the time they're going to the CAT scan, their blood pressure is dropping, take them to the OR. But the patient has to continue that journey through the hospital rather than be paralyzed in a location. The fact that a person is in a certain location doesn't mean you have to do that intervention. If I take the patient to the OR and their blood pressure improves and has been 100 systolic for 15 minutes, I don't have to cut them because they're in the OR. I'll take them to the scanner. Always be dynamic in your decision making and do your decision making to the patient's physiology, I think is probably the biggest take-home message.
Great. Another question. Raul, you said that if you had two patients who came in simultaneously, both of whom fulfilled the criteria, you wouldn't take them to the operating room for resus. What would you do if you'd started with a case in OR resus and somebody else came in who fulfilled those criteria?
Yeah, so that happen very, very often. You know, you are in the middle of an OR resus and you get two more in the trauma bay. So obviously we have the manpower to run 3 or 4 or 5 resuses at the same time in the hospital. What we don't have is the resources to run 5 OR resuses at the same time, because this is pretty resource intensive. So if we get 2, the reason we went to the trauma bay was because all the resources that we have in the OR, most of the resources we have in the OR are in the trauma bay, and those resources can be shared by 2 patients. So one attending can supervise 2 resuscitations, you can call a second attending in, you have a fellow, you have a resident, so you have the manpower, the nurses, and the resources there. It would be very difficult to decide for one patient and not for the other if those had a survival chance. So it's always a matter of dealing with splitting the resources that you have. The Japanese get this question all the time. They only have one of those rooms in their ERs. It's not that all their ER rooms are like the hybrid ERs. And how do they decide, you know? It's a problem. This is very resource intensive and expensive.
Thank you. I suppose that you probably also, do you send your sort of trauma team back to the trauma bay once you decided that you've got one of those 40% of patients that need to have a surgery? Or do you keep them with you?
No, so once you decide that the trauma OR room is going to become just a regular OR, you keep the least number of people there just to do the operation like you would do in any operating room, and everybody else redeploys to the trauma bay, including the trauma nurses, the trauma techs, the runners, everybody else. Yeah, so they don't stay. Now, it's interesting that you ask, because there are some tough cases like the pelvic fracture case that Juan just showed, the blunt trauma, and in those cases, if the resuscitation is ongoing, we kept one of the trauma nurses there, we kept one of the runners there, and everybody else went to the trauma bay for the next trauma that's about to come. But they only left after the trauma surgeon or the trauma team leader said resuscitation is controlled, we accomplished what we need, and now we're going to cut, and then it becomes a regular OR.
And are you able then, when that second patient comes in and you've sent your team back to the resus bay, are you then able to take them to an OR for OR resuscitation, or have you used your full complement of resources by that point?
So we are able to take them to the operating room. So once you are using that OR, another OR must be available by trauma guidelines 24/7, 365, right? So you use one OR, you open another room, and that other room can be utilized. So yeah, we can do more than one. What you can't do is when you get 3 or 4 at the same time and they all need it, because then the resources are not there.
Okay, thank
we
you.
never use that room for blunt trauma, hemodynamically stable, they need a splenectomy, for example. That room is not for those kinds of cases, or a gunshot wound to the leg that I'm going to do a fem pop that's going to take me 3 hours to do or 2.5 hours to do. We never did in that room. That room is specifically for the OR resuscitation patients.
Thank you, Raul. I think you've set the bar very high for us to try and follow in Europe, and I hope that at some point in the not too distant future, we'll be able to do it. Do we have any other questions from the panel or from the audience?
Jonathan, just one final comment very quickly. The things are going to get worse in the United States and in Europe because now the competition is not for just carving out a single OR for you to do this in your hospital, is the competition for the hybrid ORs. So everyone now says, oh, I have a hybrid OR, I have a hybrid OR. Yeah, how often do you use it for trauma? Because the vascular surgeons are using it during the whole day. The neurointerventionists are using it a lot, and you are pushed to use this at 2 o'clock in the morning when the resources are not there. So the competition is going to get worse, not easier.
Which is what makes life as a trauma surgeon that much more exciting. Okay, well, thank you very much. I don't see any other members of the panel who want to comment at this point. So I think I'll take the opportunity to thank everybody for what's been a fantastic webinar this evening. Raul Coimbra, Juan Duchesne, Mansoor Kahn, and Shahin Mohseni. Thank you very much for your contributions to this evening. Thank you also to the webinar team of Diego Mariani, Hayati Kurihara, Alan Biloslavo, and Mauro Zago for their input. I hope that you've enjoyed this evening's webinar. If you have, please feel free to let any colleagues of yours who haven't seen it know so that they can see it on YouTube, which will be there within the next few days. Thank you very much to all the panelists. Thank you to the audience. And I hope that you will join us again for our next webinar, which will be on a far less traumatic, but probably just as interesting subject of can we not finally agree on the management of acute appendicitis. Thank you very much. Thank you, panel. Thank you, everybody.
All right. Bye-bye.
Thank you, sir. Cheers.